Good morning. This is David Henry. I'm the Communications Manager for the City of Amarillo. I want to welcome our weekly COVID-19 broadcast for the latest in COVID-19 information for the Amarillo community. Let me go ahead and introduce who is on our panel here very briefly, and then we'll open up the statements from our panel members and take questions from our media. We are joined today by Amarillo Mayor Ginger Nelson, Casie Stoughton, Public Health Director for the City of Amarillo, Dr. Scott Milton, Public Health Authority, Texas State University Health Sciences Center, Dr. Brian Weis, Chief Medical Officer for Northwest Texas Hospital, Dr. Michael Lamanteer, Chief Medical Officer for BSA, Dr. Rodney Gonzalez, Director of the Amarillo VA, and City Manager Jared Miller. I'm going to go ahead and start. Amarillo Mayor Ginger Nelson. Mayor Nelson, how are you this morning? There we go. We have you, Mayor.
There. Thank you. I'm happy to report, Dave, that I am feeling much better. Thank you for asking.
Good.
I think the word that comes to mind the week after Thanksgiving, obviously we're still grateful, Amarillo, and I hope you had I know it's different, but probably I think just as grateful a Thanksgiving as our family did. The word that I have on my mind today is just stamina and what it takes for us to finish this pandemic, finish all of the changes we need to make, finish the choices that we've made to stay safe, and most importantly, to keep others safe and support our hospitals. We need stamina to do that. So we're in December now and our weather looks a lot like December today. But I'm just praying for you and for me to have the stamina to support our hospitals, to support our doctors and our nurses and all of our medical staff, and to just do what we need to do to get through the next few months as our numbers are still high. You're going to hear discussion today about those numbers and the details, but we're now leading the state as far as hospitalization rate in our RAC. These are serious things, and we need to have our attention on them, and our choices surrounding them need to be responsible just for making changes where we can make changes. So I want to thank you for joining us today, staying informed, and I'll hand it back over to Dave and our doctors and our medical staff.
Thank you, Mayor Nelson. Let's now go to Casie Stoughton, Public Health Director for the City of Amarillo. Casie, how are you today?
I'm well, Dave. Thank you. So as of today, there were a total of 23,883 total cases reported in Potter and Randall County, 12,833 cases in Potter County, and 11,050 cases of COVID-19 reported in Potter and Randall County. We have a total of 15,964 recoveries and 327 deaths reported in our community. That leaves us with 7,592 active cases. Each of the cases do represent a unique individual. The total 7-day rolling positivity average for Potter and Randall counties is at 22%. We've stayed in that lower 20% range for quite some time now. And the positivity rate at the drive-through testing site is at 44%. The 5-day positive new case average is at 586 new cases per day. The public health drive-through testing site remains operational. Individuals can call 378-6300 to be screened and directed to the test site. Our community remains at level red. Conditions do remain consistent with level red, as all indicators are over that threshold for being at status level red. GA32's hospitalization percentage for the 25 county Panhandle RAC region has been over 15% for over a month now. Yesterday's RAC hospitalization percentage was at 37.05%, meaning that just over 37% of all hospitalized patients have COVID-19. There's great news on the vaccine front. Moderna and Pfizer have both submitted their emergency use authorizations to the FDA. The next step in that process is that VRPAC and ACIP, both of those committees will meet December 10th through the 14th. It's possible that we could see the first shipments of vaccines later this month. That is incredibly exciting. The vaccines are showing great efficacy and safety, which is also great news. Even with this great news on the horizon, prevention is still key. Mask wearing, social distancing, hand washing, staying home if you're sick or exposed are still critical in the fight against COVID-19. And that's all I have today.
Thank you, Casie. Let's now go with Dr. Scott Milton, Public Health Authority. Dr. Milton, how are you?
I'm good. How are you this morning?
I'm good, thank you.
Good. Just a brief comment, just listening to those numbers that Casie is giving, and it just continues to show that we have continued widespread community spread in our community with a high number of active cases, a really high positivity rate, and that'll eventually translate into hospitalizations. And so we are in the midst of this surge still. And once again, this boils down to the public health measures that we know work, that include wearing a mask and socially distancing. So I would encourage everyone to continue to do those things. As Casie mentioned, a vaccine is coming, and I believe a registration form has been sent out to the healthcare providers regarding this. And so let's continue to stay vigilant here. And I look forward to hearing from our Chief Medical Officers, Dr. Weis and Lamanteer. Thank you.
Thank you, Dr. Milton. Let's now go to Dr. Brian Weis, Chief Medical Officer for Northwest Texas Hospital. Good morning, Dr. Weis.
Hey, morning, Dave. I'm a little bit nostalgic today. Yesterday was World AIDS Day. And that's a day we set aside to remember that pandemic that started 40 years ago. And many of us my age and older well remember the 1980s and early 1990s when HIV was such a scare. And a lot of the same emotions we have now, we had back then, which was, the fear, the anxiety, the despair, because we knew if you caught that virus at that time, it was 100% fatal. Now, it's amazing nowadays, because of great local organizations like the Panhandle AIDS Support Organization, or PASO, as well as the efforts of Dr. Fauci since the 1980s, as well as thousands of scientists and doctors, people who live with AIDS today can anticipate having decades of healthy life despite the virus. It is incredible where we have come with that virus. Now, we don't have a vaccine for HIV. What we do have is a lot of very powerful medicines that suppress that virus where it can't hurt anybody anymore. I think in many ways, back in the 1980s, we started to identify who was at risk, how the virus was spread. And what you notice is that people started taking personal responsibility and personal protective measures to protect themselves from that virus at that time before we had all these tools. And I know in Dallas, we saw the incidence of new infections for HIV in the late 1980s, early 1990s absolutely plummet because people were taking the personal initiative to protect themselves. I think that's where we are with COVID right now. As Casie mentioned and Dr. Milton said, we are on the cusp of having some very powerful tools to fight this virus. We already have remdesivir, which is an antiviral. We're going to see more of those coming. We have the monoclonal antibodies like bamlanivimab, which is now an outpatient treatment to hopefully prevent people at risk from getting sick from this virus. And most importantly, we have the vaccines coming, the Pfizer, Moderna, AstraZeneca, which we hope to have the first shipment in the next 2 to 4 weeks. So great tools coming. But the take-home message is until we get those in place, it goes back to the same efforts and activities that they did with HIV in the 1980s, which is protect yourself by doing the measures we know prevent the spread of the virus. As Dr. Milton said, the mask wearing, the distancing, and things like that. My hope is that 40 years from now, we will have a World COVID Day when we can look back and say, look how far we've come, and the fact that this virus is no longer of any significance to the human race, just like HIV is becoming. So that's my hope for the future. Regard to Northwest Texas. So right now we have 111 positives in the hospital. That is 22% of our licensed beds. That's actually 44% of the patients in our hospital right now. So almost 1 out of 2 patients in our hospital is a COVID positive patient. We have 45 of our 62 ICU beds have patients suffering from COVID in them. We have 24 COVID patients on ventilators right now. So again, we've been seeing this, we've been hovering around the 1 teens for about a week to 10 days now at Northwest. Jerry, our lab director, and his team are testing like crazy. We did 326 tests yesterday. we had 20% positives. So we were seeing anywhere from like the high teens up to the low 30s each day percent positives, and we're not seeing a drop in that yet. Critical care continues to be our major problem. And we are now working with, I know all three hospitals, the VA, ourselves, and BSA, are working closely with the Amarillo Public Health Department and the RAC to try to expand critical care capacity within the walls of all three major hospitals. So we really think that's our big initiative now is to continue to expand critical care capacity, because I know there are patients out in the regional facilities that need that higher level care that right now we just cannot accept into these hospitals. The tragic thing is we had 70 deaths from COVID-19 in November at Northwest. That's compared to 20 in October. We had 3.5 times the number of deaths in November from COVID. That's unacceptable. That is a tragic number, and we've got to do better. As we talked about some of the tools we're using, we now have this bamlanivimab, which is this outpatient antibody. As Casie said, this is on an EUA, or an experimental utilization authorization, meaning that it's only for very specific patients based on what the FDA is telling us. But we're now learning how to use this better, and we'll continue to try to offer it to those patients that are appropriate based on that EUA. We continue to use remdesivir in the hospital, as well as Decadron. With regard to the procedures, the surgical procedures, we continue to go case by case. If we can have a patient come in for a procedure and not have to stay overnight, we can do that procedure. If they do need to stay overnight, we will have to make sure that we have a bed to accommodate them. And we're doing that without taking any resources from COVID-19 patients. So, but we're case by case, and we are having to cancel some procedures if we just cannot accommodate them. Lastly, I just want to say, yesterday we had a patient come to us that is co-infected with COVID-19 and influenza. That is the combination that we've been fearing. Okay? Once again, please, influenza shots, the flu shots are critical. This patient is very sick, and we know that that is a bad combination. So this is the first patient we've seen in the fall with this combination, but please, we want to avoid this, and I plead with everyone, continue to get your flu shots. They're still available, and it's never too late. Dave, that's all I got for today. Thank you.
Thank you, Dr. Weis. Let's now go to Dr. Michael Lamanteer, Chief Medical Officer for BSA. Dr. Lamanteer, how are you? Let's try again. Dr. Lamanteer, if we can.
Sorry, I was on mute. Apologize. Good morning, everybody. Thank you for David for having me on the panel again today, and thank the panel members for their opening comments as well. I agree with Dr. Weis in terms of kind of the state that we're in right now with inpatient hospitalizations. You heard the mayor say that we have the highest hospitalization rate in the state, and we certainly are bearing the brunt of that here with our two hospitals in the city. At BSA currently today, we're up to 194 confirmed cases in-house. We entered the holiday weekend in the low to mid 180s, and today we're up to 194. It seems as though as many patients as we discharge, we get that many more coming in with new admissions. And that wave of patients coming in with COVID symptomatology has not slowed down, unfortunately. Dr. Weis mentioned that they've seen their first patient with co-infection, and we've had several patients with co-infection with influenza B. That's one of the strains of influenza. And again, that can vary from year to year as far as the type. We've seen most of our cases be influenza B, and we've had several co-infections now with COVID-19. Of those 194 patients that we have in the hospital, we have 86 total ICU patients. Of those 86, 72 are COVID-19 ICU patients. I think that is an astounding and disturbing number in terms of where all of this ICU volume is really evident. Obviously, it's the COVID-19 population of patients that are causing the greatest strain on our ICU resources in the city. You heard Dr. Weis mention that we're working on an effort to see how we can potentially augment our ICU beds, and that is absolutely the case. We're looking at what we need from a staffing and resource standpoint from the state, supplying a lot of those resources, because we are tapped out. We don't have additional staffing. We don't have additional equipment. The state has been really fantastic thus far in providing a lot of those things that we need: extra ventilators, extra staff, whether it's nurses, whether it's respiratory therapists, whether it's physicians. We've been getting help from multiple avenues because we need that help. We can't handle it with the internal resources that we've had. With the need to expand the intensive care services within the walls of the hospital, that obviously is creating an issue with what we can do with the other non-ICU patients and med-surg volume. And therefore, we're looking at other ways, and we've started already with our surge planning to create additional capacity on floors that have not had patients on them for some time, simply because of our hospital typical average daily census has not warranted that. So again, the med-surg capacity, we still have some ability to grow. But what we're seeing is that the preponderance of patients that come in with COVID-19 are requiring ICU services. And that's where we are at our maximum. And again, the ability to expand further is going to be, even though we're working on this project, it's going to be very difficult to get there. And my concern is that if we need to expand in the next 7 to 10 days, we may not be able to have the resources here to do so that quickly. So again, it's critical that we're doing everything we can to mitigate that surge. And what we can do is avoidance of gatherings with significant numbers of individuals, masking, doing good things yourself and from a personal hygiene standpoint when you're out in public, and sneezing and those types of things. Even when you're wearing a mask, washing your hands often, all those types of things that are going to help prevent not only COVID-19, but other infections. So please, be diligent with those efforts to protect not only yourself, but your family, your friends, your loved ones, and others. Right now, we're using about 70% of our ventilators, and the only reason that we're at 70% and not higher is because we had a significant augmentation in the number of vents that we have available because of the RAC providing us with additional ventilators. That has been an ongoing issue in terms of one of the critical resources that has helped us get through this pandemic. We're also using about 50% of our high flow oxygen delivery devices. And again, that has helped us to stave off the ventilator for some patients. Our quarantines of employees are improving. That's one bright spot. We have 115 employees quarantined. That's still a big number, but that number's down from about 150 last week. Out of that 115, we have about 40 nurses that are on quarantine currently. That number is also down a little bit, and we're continuing to work with our system in terms of optimizing our return to work protocols that are within CDC guidelines and that are safe and allowing people to come back as able when they're healthy and ready to do so. From a testing standpoint, we now have initiated antigen testing, as I mentioned a couple weeks ago, across multiple ambulatory sites that we have in addition to the hospital. The antigen tests we're seeing are probably slightly, I would say slightly inferior to the PCR testing, although the data on the antigen testing is quite good. When you talk about some of the statistical language we use, such as sensitivity, specificity, and positive predictive value of those tests, which are terms that help us determine how good a test is, those tests continue to score very well in those areas. It may just be a timing issue when we're doing some of these antigen tests either too early or too late after the onset of symptoms, and really is getting us in a situation where we may have a false result. By and large, I think those tests are quite good. Beyond that, we still have some constrained resources with some of the rapid test kits. We do have a fair supply right now at BSA, but that is a national shortage that's ongoing. So we still have to send out some of those PCR tests on certain patients as opposed to doing everything internal with our own Cepheid rapid device, which is part of the reason why we have to rely on this antigen platform to expand our overall testing capacity, which is critical. It's better to test folks a couple times on an antigen platform than not be able to test them, or to give them a delayed response 3 or 4 days after you test somebody, which really is problematic, as you can imagine. We're excited about the plans in preparation for the vaccines that are coming our way. You heard Casie mention and Dr. Milton and Weis mention the timing of those. We are preparing as need be and working with the Department of Health, working with our city partners to make sure we have the ability to handle these vaccines and store them properly, and then working on the hierarchy to get folks vaccinated. I know there's a lot of apprehension about vaccines in general, whether it's COVID-19 or the flu vaccine or what have you, but please, please, please make sure you're verifying the source of information you get when it comes to any type of health remedy, let alone vaccine therapies. There's a lot of misinformation out there, and certainly for most of our patients, the risk of getting a vaccine is far, far less than the risk of getting COVID-19 and the potential complications that come along with that. Elective cases at BSA, changing gears a bit, we continue to do what we've been doing now for, I would say, a couple months at least, and that is scrutinizing surgical procedures that can be delayed and pushed off, and allowing those that can't be delayed and pushed off to move forward. We're very tight on ICU beds, as you can imagine. So any surgical procedure that requires an ICU bed is one that has to be deemed such that it can't wait because of the potential risk for that patient and the potential bad result, if you will, that could come from waiting. So as you'll notice, if any of your family or friends have worked at either of the hospitals, surgical volumes across the city are down significantly. And that is because the number of elective cases that historically have been done have had to be canceled or postponed while we handle a much more acutely ill medical population that is demanding our hospital resources. So that's really where we are today for BSA. Again, we say this every week, and we mean it from our hearts every week. We can't thank our staff enough for what they're doing every day in and day out, sacrificing themselves to take care of our patients, take care of our community. It's all of our healthcare workers on the front line that we owe a lot of credit to. When you see them in the community, thank them, tell them thank you, and we appreciate their hard work. That's all for me, David.
Thank you, Dr. Lamanteer. We now go Dr. Rodney Gonzalez, Director of the Amarillo VA. Dr. Gonzalez, how are you today?
I'm doing well, David. Thank you. So first, I'll start with our numbers. In our hospital right now, we have 15 COVID positive patients, 8 of which are in our ICU and 2 of which are on ventilators. Now, as I've mentioned a couple of weeks ago, we have started accepting non-veteran patients through agreements with FEMA and the VA to accept. And currently we have 8 non-veteran patients, 7 of which are COVID positive that we are taking care of. I mentioned this since we've started this, we have actually accepted a total of 18, what we call fourth mission or non-veteran patients that we have assisted with their care during this COVID pandemic. As we continue to face the community spread, I do want to just remind our veterans that if you have appointments here at the VA and you do not want to come in, please reach out to us. We may be able to do that through a virtual method, whether through telephone or video connect, and we'd be happy to explore those options with you. I do want to remind veterans to get your influenza vaccination. We still have it. Please call, let your team know, and we can arrange to get that for you. The other things to remember is this Monday, we have Pearl Harbor Remembrance Day coming up. December 7th, 1941, Pearl Harbor was attacked, and we lost many Army soldiers, Navy sailors, and Air Force airmen during that attack. And you know, that spurred what we now know as the greatest generation. Why do we call them the greatest generation? Because these were men and women who answered the call to respond to an emergency to the nation. And that's some of the things that we can learn. We have an emergency in our nation, and it's called COVID right now. And I'm stealing some of the thunder. I think Dr. Weis said 3 weeks ago during Veterans Day, this is a battlefield for us, and we all need to do what we can to protect ourselves and protect our community. And what is that? That is wearing your mask. That is practice social distancing. That is good hand hygiene. Not going out if you are ill. And so I just encourage please, let's just take a lesson from the greatest generation that responded, some voluntarily, some by draft, that responded to preserve our nation at a time at which it was attacked. And please, let's use those same lessons here. As Dr. Lamanteer is, we can never thank our employees and our staff enough. Absolutely. We want to just highlight our employees that worked over this holiday weekend. I got time to be with my immediate family because, as I mentioned a couple of weeks ago, my extended family, my parents and my wife's parents that were going to travel into town didn't because of COVID. But I still got time to spend with my wife, my children, and that didn't happen for those that were working. They put in countless hours. And as you know, someone in my staff reminded me is that often those few staff are the only face of healthcare that these COVID patients have, because we've restricted visitors, restricted other people walking through. I myself, do not go up on the COVID unit. There's no reason for me to be there. I'm not participating in that care. So the best thing is to keep everyone safe. And so often they are the face. And so we really appreciate all they do for taking care of those patients and what they're doing for our entire community. So once again, thank you for this opportunity to talk to my fellow veterans.
Thank you, Dr. Gonzalez. Now I'll go to City Manager Jared Miller. Jared, how are you today?
I'm good, Dave. Thank you. All right. So the drive-through testing center, as Casie stated, is still up and running. If you have symptoms you feel might be COVID, call the Public Health Department at 378-6300, and they'll screen you on that call for a referral to the drive-through testing site. They'll refer you to that. If you don't have access to transportation, Amarillo City Transit is providing free transportation to and from the drive-through testing site so that you can get tested. If you need that transportation resource after you've called the public health to get the referral to the drive-through testing site, please also call 3095. That's Amarillo City Transit to be able to arrange the transportation to and from the test. We want to make sure everyone has access to the test. We are currently operating under two primary governor's executive orders. There's a number in place, but there's two that primarily affect us and all of our citizens. That is GA 29. That is the governor's executive order that requires every person to wear a face covering while they're out and about when they're in different businesses and different situations. There are some exceptions, but they are few. So the governor's order requiring the face coverings is still in effect. Governor's order GA 32 is the order that primarily defines at what capacity can our businesses and different workplaces operate. As an area of high hospitalization, for the most part, we are at 50% occupancy allowed. There are certain essential businesses that can operate at 100%. I should note that whether the business is at 50% or is an essential business or otherwise defined as able to operate at 100%, all are required to adhere to all of the governor's orders, the recommendations for sanitation efforts, hand washing, wearing of the face coverings, et cetera. We have made a number of steps in light of our current challenges at the hospital and the rate of transmission in our community of coronavirus inside the city organization to make sure that we are minimizing face-to-face contacts as much as possible. We have an alternative service delivery plan that affects almost every single one of our departments. It certainly affects all of our outward-facing departments that facilitate services to our residents. If you have any questions for how those departments are changing their operations to be able to minimize face-to-face contact and to be able to provide as safe service as possible, I can certainly answer those questions during the Q&A portion. We've also, over the course of the last week, last Monday, approved on 2 readings a COVID-19 pandemic emergency measures ordinance, which basically takes items that are already in state statute, puts them into city ordinance as well, and is completely consistent with state statute, governor's executive orders, CDC guidelines, and DSHS guidelines. That's all I have, Dave.
Thank you, Jared. We're now going to go to members of our media. We have a question for an individual panel member or the panel as a whole. That's perfectly fine. Let's go ahead and start with, if I'm not mistaken, Kevin Welch of News Channel 10, KFDA. Kevin, how are you?
I'm good, Dave. Hi, everybody. So, Casie, I guess, can you tell me who decides when a patient is, quote unquote, recovered it goes into the statistics?
Sure. So the way we have done that really since the beginning is when they're at least a minimum of 10 days recovered. So and we follow those CDC guidelines. So 10 days from the date of their positive test, and then at least 24 hours recovered or 24 hours fever free, then they are considered to be recovered. If we don't have any information for that person, perhaps we didn't get their information in like a mass testing event, or we weren't able to get a hold of that person. So we generally will call three or four times and then send a letter. Then if we're just not able to get a hold of that person, then we will wait 4 weeks before we move that person into the recovery column, so that that gives us time to know if they, a general amount of time to know if they're going to either recover or if we're notified of a death.
Okay. And doctors, has the length of hospital stays changed over time from when we started this until now?
I'll start. I would say not, excuse me, not really, in the sense of the people who get very sick, and I know Dr. Lamanteer talked about this, those that get sick that end up in the ICU, it is not uncommon to see them stay for 10, upwards of 20 days a lot of times. So we get the two populations. We get those that come in that a lot of times will show a pretty rapid response to remdesivir, to the Decadron, and they may stay on the med-surg floor, and they may be able to leave within a number of days. But the critically ill patients, they're with us oftentimes for weeks, and that's been about the same since the beginning of the pandemic.
Yeah, I would agree with that. There's not really a difference in terms of length of stay. It's more about, as Dr. Weis mentioned, whether you're requiring ICU services or not. And if you do, and especially if you require mechanical ventilation, that's where we see the longest length of stays and the greatest risk for mortality, unfortunately.
Okay. And over this holiday weekend, we had a very large amount of deaths, and relative to what we've had, is there adequate morgue space for these victims? Or I don't know if you call it that, but how do you deal with that?
So we actually, we're seeing around, well, so that was the total number of deaths that were reported to public health from Wednesday or from Thursday to Sunday. And so it was, that number was spread over those 4 or 5 days, which was what we expected over that amount of time. I'll let Dr. Weis or Dr. Lamanteer, do you all want to talk about the mortuary space?
Yeah, all I know is that, yes, we have the RAC has had to bring in several morgue trucks for storage of the deceased bodies. And yes, at this point, we're having to use those. I believe there's 2 of them present right now in Amarillo. I've not heard about the need for a third, but certainly we have heard an appeal from the mortuary and from the funeral homes saying that, yes, that they are getting backlogged on processing some of the deceased bodies. So, yep, it is what it is. We are unfortunately putting a lot of pressure on them.
That's correct. I would just say that I echo those comments, and we're very concerned about it. And there's no question that November was a very bad month for our city and our community when it came to a number of deaths. And it looks like approximately, just to give you a ballpark, approximately a third or more of the deaths we've had since the outset of the pandemic have occurred in November. And that is a unsettling statistic, in my opinion.
I think, again, just why it highlights the need for continued mask wearing, social distancing, staying home if you're sick or exposed. Those prevention efforts are just key in this fight against COVID right now.
Okay. Casie, how's the response time on the drive-through testing?
So that is that hasn't changed. So we're still seeing generally 24 to 48 hours with lab returns. People have access to the portal, and we give them a handout when they come through the drive-through testing center, and then we're able to do their contact investigations very quickly because we're their provider, and so those are certainly a priority with contact investigations.
And as far as the report card, are your numbers as of yesterday caught back up from the holiday weekend, or are we still going to see some extra coming in?
There may be a little extra. I'll have to check with staff. I haven't heard that there's a large backlog, but I'll have to check with staff and get back to you.
Okay. And the DSHS, one of their websites is showing that Lubbock County's overall testing is about twice that of Potter and Randall combined. Do you know why that is?
I can't speak to Lubbock County, but what I can say is that in public health, we report every single test that's reported to us. And we know that there are likely tests, especially negative tests, that haven't been reported to us. And that's okay. It's helpful to us if those tests are reported to us, especially for this kind of number. But we don't have, we likely, that number is underreported for us. And so we certainly report every test that's reported to us. And so we'll continue to do so.
Okay.
Mayor,
But do you know if those numbers? Yeah, I was just going to ask, as the parent of two college kids, I know that the colleges where my children are doing regular testing, they're doing random testing. So having that college there as a testing resource, and they're also requiring their students who are not a transient population, but they come into their city and then they're gone. I just wonder if that would boost, that's definitely a difference between our communities. Something that Lubbock has inside their city that we don't have, that might explain a drastic increase in testing. Just a thought. I haven't studied that. I just wondered.
Yeah, I do think that that's a possibility. Their population isn't much higher than our population, but their population surges dramatically when college is in session. So I think that that's certainly something that is a possibility. I also know, in fact, I just was confirming with our team, we're not turning people away from the drive-through testing site. And so there is capacity and access for people to be tested who need to be tested. And I think that that's probably true. Northwest said today that they tested over 300 patients yesterday. So that's a good thing, that if people need a test, that they're able to be tested. And so we're not having to turn people away, and we have the ability to surge staff if we have the need for that at the public health drive-through. And so we will continue to accommodate and serve our patients as needed.
Okay, that makes sense. Thank you, everybody.
Thank you, Kevin. Let's now go to Morgan Durden, 7. Morgan, how are you today?
Hi, Dave. I'm good. How are you?
Good, thank you.
My first question's for Casie. Do you have the age demographics for patients who are being hospitalized, and if you knew how many people are from the actual Amarillo area?
I don't. That would actually be a great question for our hospitals.
Okay. I don't know if the doctors have the information right now.
I really don't. I can just tell you we've got ages range from 20s and 30s all the way up to very, very elderly, 80s and 90s. But I cannot say exactly how many are from the local area, other than the fact that we have not been able to really accept a lot of patients coming from the regional facilities. So most of the patients we have are ones that are walking into our emergency room or being brought in by local EMS crews for care.
And I agree. I don't have exact statistics on our total COVID admitted population in terms of the age demographic. I would say that it was, as I talked about earlier in the pandemic when we last pulled this, when you talked about the younger age brackets that were showing the greatest numbers of infection in our two counties, meaning the 20-year-old decade, 30-year-olds, 40-year-olds having the highest numbers of actual cases. The hospitalization was occurring in the older age brackets more so. And the mortalities are also occurring in our older patients more so. It looks for us like about 2/3 of the mortalities that we've had in November, for instance, were patients that were 70 years old and older. About another quarter of those mortalities are patients in their 60s. And then a small percentage, less than 10%, in those that are less than age 60 when it comes to the hospitalized and then the mortality demographic.
Okay, thank you. And then my last question is also for the doctors. I've seen a lot of people say that as we get 500 cases per day, we could reach this herd immunity or breaking point. And I just want to know how realistic that is, and at what price does that come?
So I think that it's not clear exactly what the percentage of individuals that are infected in our community. I saw last week that I think the CDC was estimating that around 8 times the number of confirmed cases nationally may be the actual number of individuals that are infected. But those are just estimates based on kind of statistical models. There are some models out there that that are suggesting that we may be reaching a plateau. And then to answer your question about what cost there is, well, I think you can see by these numbers that our CMOs are telling us about how many deaths we've had and how many deaths have occurred within the last few weeks. Close to half the individuals that we've lost have been in the months of October and November. So you're seeing the cost of what's happening when you have widespread community transmission of this, and it's stressing the hospitals to capacity or beyond capacity. So a vaccine will obviously help, and that will be starting to be administered relatively soon, but in small quantities. And really, it leaves us with, as we've said many times, with these public health measures that are going to be so important, of wearing a mask and socially distancing. So that's kind of my comment on where we are relative to herd immunity and deaths, et cetera.
Thank you. That was all I had.
Thank you, Morgan. Let's now go to, if I'm not mistaken, Aaron Langston, KAMR Channel 4. Morgan, excuse me, Aaron, are you there?
Yeah, I'm here.
Hey,
How are y'all?
Good. How are you?
Pretty good. First question. In the past couple of weeks, it seems like our number of patients going on the vent has been going up little by little each week. And a few weeks ago, one of y'all said that once a patient goes on the vent, a lot of times they don't come off. Is that a scenario that you're still seeing even with these numbers going up, or is that trend tending to fade a little bit?
I'll start. So absolutely. We know that we need to make every effort to keep a patient off a ventilator, because when they do go on a ventilator, their prognosis becomes significantly worse. And I can only speak for Northwest, but I would say, and I know Dr. Milton sees a lot of our patients, a lot of these patients, when they go on a ventilator, these are the ones that we ultimately end up withdrawing care, just due to the fact that at that point they cannot survive without the ventilator. So that is a bad prognostic development if you go on a ventilator.
Yeah, I think the mortality probably approaches 50%.
Alrighty. And I've asked this before, but we're still in that situation. Are we still approaching the possibility of going outside the walls of the hospitals for care of COVID or non-COVID patients?
I'll start with that answer. And the short answer is yes, we're considering the possibility because we're trying to prepare for all potential circumstances. But as we've stated many times, that is not ideal. So again, we're doing everything in our power to work with the state and city officials and the public health department and collaboration between the hospitals to see what we can do to maintain as many beds in the hospital as possible. When we're inside the walls of the hospital, we're able to provide better care. That is leading to situations where we have double occupancy in semi-private rooms in some floors, in some situations, just because we need that extra bed capacity. But again, providing especially intensive care services is best served in the walls of the hospital and not elsewhere.
I would just say, seriously, I know talking to Dr. Lamanteer and I, one group that we have not recognized at both hospitals is the plant engineering guys at both hospitals. I mean, they have literally physically redesigned these facilities to try to accommodate more patients and particularly more critical care. So we talk about turning whole units into negative pressure and changing all kinds of flows and walls and stuff. So these guys are phenomenal and they've done an amazing job, but all in the effort as best we can to keep it within the walls of the hospital. Whereas Dr. Lamanteer says, we don't want that voltage drop that if we send the patient out to another facility, which is going to happen because they don't have the same ancillary support that we have in the hospital. But yeah, our plant engineering guys at both BSA and ER have done an amazing job trying to accommodate everything we've asked them to do.
All righty. And I believe it was last week, somebody mentioned that there was concern of, as other parts of the state needed assistance with staffing and equipment, that some of the resources we have been using from the RAC might be pulled away to go elsewhere. Since then, a lot of the other parts of the state have hit that 15% hospitalization rate that had been under it before. Has there been any talk from the RAC or the state of pulling some of those resources?
I would say not to my knowledge.
I would agree that the RAC has not reported that pulling out any resources this time. Obviously, this is a potential inevitability, which is that we only have so many healthcare workers that are trained and licensed to provide care. So if we start to surge in other areas of the state, we're going to have to share those resources. So it's a concern, but no, there has been no immediate declaration that staffing is going to be pulled back.
All righty, I think that has me covered. Thank you very much.
Thank you, Aaron. Let's now go to David Gay of Amarillo Globe News. David, how are you this morning?
I'm all right. Good morning, everybody. I guess I have two questions. The first question is representatives from the hospitals here on the call. Do you guys have information in front of you about how many individuals have been treated with the various treatments, whether it be Decadron, Remdesivir, or BAM, that have been treated so far?
David, I'll just say at Northwest, we've treated about 500 patients with Remdesivir. I'd say probably Decadron about the same, if not a little bit more. With regard to the bamlanivimab, I think we're still in single digits as to how many we've treated, just as we continue to try to gear up for that administration.
Yeah, and at BSA, we have treated hundreds and hundreds of patients with dexamethasone and also remdesivir. no question, once the EUA, the emergency use authorization for remdesivir, allowed us to treat all hospitalized patients, we became very aggressive with that drug in trying to benefit our patients with early administration for those who qualified. Dexamethasone as well, which I would say to date has really the strongest evidence in terms of a benefit for certain patients. We have not yet received allocations of the monoclonal antibodies. We've accepted them and we've been told they're on their way. They have not yet arrived on our doorstep, but we anticipate those to be here soon. However, it does appear initially these are going to be in very limited quantities. So again, this is going to be something where we have to try to find the highest risk patients and try to direct those therapies to those individuals.
So on that, for Dr. Weis, what have you seen out of the initial treatment of BAM, of the antibody?
Yeah, so David, just in support of what Dr. Lamanteer is saying is, please remember that the indications for this medication are very specific by the FDA. So these are for typically patients over 65 or over 55 with at least one comorbidity, or any age group, particularly patients who may have an immunosuppression or condition that causes immunosuppression. What we're finding is, first, it's very well tolerated. So all the patients we've done have been able to take the medication without any real side effects or reactions to it. So it's very well tolerated. It's a little bit early. I mean, just anecdotally, some of the patients we've treated said that they felt that they saw some improvement within 24 to 48 hours. But just remind you, it takes, based on the data, it takes 14 high-risk patients to be treated to prevent one hospitalization where the patient might become very sick. Again, that's great. I mean, that's something, but we've got to treat 14 to 15 patients to really to avoid one hospitalization. But so far, it's been going well in terms of just the people we've treated have done very well with it and it seemed to tolerate it very well.
Absolutely. And I know, Dr. Weis, you spoke about the first COVID-19 and flu patient at Northwest. And I believe Dr. Lamanteer said there's been multiple BSA. Without getting into too many specifics, Dr. Lamanteer, how have those patients done in the hospital? Is it as intense as you guys were fearing?
I don't have specifics on those individuals, and I really shouldn't talk about any specifics on those patients, just to simply say that we know from our prior experience back in the early part of the year and our fear knowing what the potential morbidity is for both of these viruses, that having a co-infection is going to put those patients at much greater risk for significant complications, potentially prolonged respiratory failure, and even potentially death, unfortunately. So it is a concern, and that's why we're stressing the need for influenza vaccination. Obviously, if you haven't had it yet, it's not too late. It's not too late throughout the entirety of the flu season, for that matter. And it's the serial flu vaccines that you get year after year that are probably giving you the greatest benefit, as opposed to a one-time flu vaccine, but it's never too late to start. And I'll just, again, please, I want to emphasize that point.
Absolutely. I guess the last question is, when is it expected for the potential cases caused by Thanksgiving gatherings, Thanksgiving travel? When are the public health department or the hospitals, when are those kind of scheduled to maybe start popping up?
Typically what we see with patients is if they become symptomatic after infected, they develop symptoms within 5 to 7 days. And if they require hospitalization, it's usually 10 to 12 days to 2 weeks later.
So are the hospitals preparing for a potential surge on there?
We've been preparing for months, no kidding aside, but that's all we do every day and night is prepare. And I'm not trying to be facetious, but that's the truth.
Mm-hmm. Sure, absolutely. Absolutely. That's all the questions I have. Thank you, guys.
Thank you, David. This concludes our news conference for today. Once again, we do these every Wednesday at 11 a.m. I'm the communications manager for the City of Amarillo. I want to thank all of our panelists who took the time today to provide this information to the community. Thank you for your service, and thank you for providing this information. We will see everybody next week. See you then.